Thank you, Mr. Chairman. Thank you, Colonel Womack, and thank you, Mr. Hadley and the Congressional Budget Office for being with us. I speak with my constituents in my district in Pennsylvania on health care quite regularly. We very often discuss three priorities that are important to their families. Those are the ability to choose their own doctor, quality, and affordability. I'd like to focus my questions on these areas. First, regarding choice, Deputy Director Hadley, page 6 of your submitted report says, and I quote, "Participants would not have a choice of insurers or health benefits. Compared with the options available under the current system, the benefits provided by the public plan might not address the needs of some people." Close quote. Can you expand on what you meant by that?
Sure. So as I go on to say, one of the issues is about technology and how quickly a new set of insurers might adopt technology and changes in treatment patterns. And so, for example, you might expect that if there were competing private insurers, that one or two of them at least would have adopted the new technology, and that would cause the others to follow. And so you would expect in general you might have faster adoption of new technologies than you would with one payer.
Right. So more is better and competition is good. Regarding quality, I've often heard the Canadian healthcare system described as it's terrific until you get very sick. People want to be able to go to the doctor of their choice and know that the care they are receiving is excellent. I'm concerned that when the single-payer system removes choice, as we've just discussed will happen, people will not be able to choose the doctor that it best suits their particular and personal health needs. Have you analyzed how the single-payer system could and would negatively impact the quality of care that people receive?
Well, so we've thought about both doctor choice and quality of care. So let me go through doctor choice first. So it's possible that if you had a single-payer system, there might be more doctors to choose from because essentially all of the narrow networks would be combined, and you'd only have all providers would be in one network, depending on design choices. In terms of quality design, it depends on so many of the other, in terms of the overall quality, it depends on so many of the other factors. But if there is a mismatch between the demand for care and the supply of care, then you would end up with increased wait times and problems with access to care. And to build on that just a little bit, that might mean, for example, longer needing to travel further distances to see doctors.
So based on models that we're aware of, quality would be compromised?
Unfortunately, I can't answer that directly. It depends on the design of the system and how you are, but the extent to which you are expanding coverage and expanding the services that are covered and reducing copays, those would all tend to increase the demand for services. But if the total cost is then being controlled by reducing provider payment rates, that would tend to cause a mismatch between supply and demand.
All right. Let's talk about affordability. I'm concerned about the affordability of a government-mandated and run healthcare system, both for patients and the American taxpayer. To pay for implementation of a government-run system, what would be, coming from the Congressional Budget Office, some of the ways that the revenues would be generated?
We discuss kind of three ways it could be financed through cash flows, and then there's a kind of a half. So you could have additional copays or other cost sharing by individuals. There could be premiums paid or taxes in some form or other. And then the half is you could have deficit financing that would postpone when those services would be paid for and shifted to another generation.
Right. In a system with no cost sharing, such as copays and premiums, run entirely by the federal government, the only method to generate revenue would be taxes or deficit spending. No copays, no premiums, all paid for.
If no copays and no premiums.
Right. And this system I described in my last question is what H.R. 1384 is all about, a bill co-sponsored by 108 of my Democrat colleagues, including 10 from this committee. The Medicare for All Act of 2019. The bill contains no cost sharing, thus taxes is the only way to pay for it. We know from independent studies that this will cost roughly an additional $32 trillion over the next 10 years. That's an average of $10,000 per person. For a family of 4 in my district would be paying $40,000 for such a plan, that on top of what we're paying now. That is simply not sustainable. Based upon your testimony here today, a single-payer system would result in the elimination, minimizing choice, a quality would be suspect, and $10,000 per person in new taxes. Certainly not affordable. One can conclude a government-run single-payer health system creates a monopoly that will expand the role of the federal government at the expense of patients and taxpayers. I do appreciate the CBO taking the time to join us this morning, and I urge my Democrat colleagues to work with us to develop a plan that will actually deliver on what's being asked for by the American taxpayer: choice, quality, and affordability. The government takeover of health care will make our system and many of us sick, $32 trillion sicker, not better. Thank you, Mr. Chairman. I yield back.
Gentleman's